Sheila is a professor in the Department of Medical Science at the School of Veterinary Medicine, University of Wisconsin-Madison. She earned her Bachelor in Biological Sciences from Cornell, her DVM from the University of Georgia. Sheila completed her internship in large animal medicine in Ontario Veterinary College and her MS and PhD at Ohio State. She is certified with the American College of Veterinary Internal Medicine. Sheila.
Thank you very much. I want to express my gratitude to the organizing committee for giving me this talk at nap time. So I'm gonna do my best. It used to be I was given a lot of calf diarrhea talks in the afternoon, and there was this old advertisement. I think it was a Pfizer or one of Pfizer's company, and it was an advertisement for people, and it would say, give me a moment to talk about diarrhea. And so I'd like to take this moment to talk about calf respiratory disease, and I'd like to switch over, tag along with what Walt presented this morning, and talk about calf diarrhea, or calf respiratory disease. Respiratory disease in young calves, we've seen the data this morning. Walt gave a great overview. It's significant. The challenge is we have to diagnose it, and in a live animal, there's no gold standard way of making a diagnosis. And so all of the things we are trying to do for early detection and effective treatment are hampered by the fact that we can't get really good sensitivity, specificity, predictive values because of the lack of a gold standard in a live animal. That said, I think there's pretty uniform agreement that clinical signs of respiratory disease are agreed upon. Fever, cough, ocular discharge, abnormal ocular discharge, nasal discharge, abnormal breathing, auscultation of abnormal lung sounds. And as pointed out this morning, the challenge is that not all of these occur simultaneously. Not all of them occur with every agent. There's an influence of timing, whether lesions are active, and so clinical sign diagnosis is also somewhat hampered and challenging. Another thing to note is that routine screening for health problems, you have it in the beef industry with pen riders. We have it in the dairy industry for fresh cows, but routine health screening for problems in calves is relatively rare on the dairy. In terms of respiratory disease screening tools, a number of them are out there, and the recognition in the industry, especially in the preweaned calf where respiratory disease diagnosis is particularly challenging. A number of enhanced technological tools, and we saw Whisper this morning, but a number of tools are emerging and I think are going to help us, and they are accelerometers, pedometers, appetite-based detectors, actual feed consumption monitors, remote temperature recording, radiant heat exhibition from the skin, electronic stethoscopes, thoracic ultrasound. And again, the problem is that the sensitivity and specificity, it's hard to validate these tests in a live animal because we're limited to no gold standard. So it makes it challenging. The clinical signs-based respiratory scoring system that I'm going to delve into and present is based on a severity score for the selective clinical signs that I'm talking about. And it's something that we boiled it down. We left the stethoscope part of this out, but we boiled it down to the clinical signs that appear most commonly in the literature that are at least fairly representative of respiratory disease. They're not pathognomonic for respiratory disease. Again, they don't occur simultaneously, but to some degree they're the best we have. And they're rectal temperature, cough, and in this case I'm asking the examiners to not only determine spontaneous coughing, but then to have some hands-on contact with the animal in which they compress and shake the trachea to induce cough, to look for abnormal nasal discharge, abnormal ocular discharge, the ear position or the activity of the ear, and then to make it simple and farm-friendly, I've taken 4 of these parameters. So what I've done in the preweaned calf is use rectal temperature, nasal discharge, and then ocular or ear score, whichever is more severe, and we'll go over that in a minute. So using the 4 parameters, then we sum the severity score, and this will make more sense in a minute, but a total score of 5, provided that at least 2 clinical parameters are moderately or severely abnormal. So 2 clinical parameters have to be abnormal to get a positive calf. The initial design of this respiratory screening tool in calves was that this be implemented in preweaned calves on a regular basis, a minimum of twice weekly. I know that doesn't occur. When it doesn't occur on a twice-weekly basis, it can start occurring at 2 or 3 weeks, whatever the onset of respiratory disease is. It can be done pre-weaning, pre-housing change, so that we can at least have a handle on it. But when it's done repeatedly and consistently, and calves are rechecked, then it ends up being a tool that can be very useful. And especially when it's coupled with effective treatment. The goal is to reduce post-weaning pneumonia, chronic respiratory disease, endemic respiratory disease, otitis media in pre-weaned dairy calves. Again, this is repeated many times this morning. Correlation between clinical signs and postmortem lesions depend on the severity of the disease, the duration of the disease, the timing of the screening, perhaps the agent that's used, perhaps the management, perhaps the nutrition. There are a number of things that affect this interpretation. And yet, I personally am not deterred by this, because the goal here for me is to get some sort of usable detection system in place on a regular basis on the dairies, so we don't miss these calves and lose them as future production animals. The details and the statistics and the figures were reported this morning by a number of people. The bottom line for this slide for me is that it's an expensive proposition. When we look at the economic toll, that would be treatment expense, morbidity, premature culling, reduced growth, reproductive indices that are suboptimal in these calves. The most recent study, and this is a Dutch study, looks at 36 as a median treatment, all the way up to 65 US dollars per calf. So it's a costly disease in calves, and a disease that obviously has economic consequences. Respiratory disease is difficult in calves. The challenge is, formerly with our somewhat limited milk feeding programs, calves were hungry. Calves fed twice a day are going to be hungry for each feeding. And in a survey we did through the veterinary students on farms and in practices last year, it is clear that most of the farm detection of disease in dairy calves, young dairy calves on milk, is an appetite-based detection system. And appetite-based detection systems are flawed. And many of you have the experience of working with automatic calf feeders now. And even there, the ability to detect volume consumed or time to consume will not be an accurate reflection of the level of presumed respiratory disease, at least based on what the system I'm going to show you. So respiratory disease diagnosis is flawed, and it's there because there is a lack of veterinary input in calves in general. More specifically, how many veterinarians go to the calves on a regular basis and work with the calf workers and find out what the current problems are, or work with them and training them to find them, training them and helping them understand the importance of respiratory disease. Poor knowledge of clinical signs, again, because clinical signs show up at different timing. The obvious ones are easy to detect. but the earlier clinical signs may not be known. The people doing the training, doing the screening, may not speak the same language as the people on the farm who are doing the treating. Appetite-based screening, as I said, is the most common form of screening, and that is very insensitive. Inaccurate detection methods, the timing of screening. Remember, a dairy calf is going to sleep 16 hours a day. And basically with a 2-time, even a 6-time-a-day feeding schedule, they eat and they sleep. So detection based on attitude and depression is very, very difficult in this set of animals. And yet, for 30 minutes after eating, they're apt to be standing, and then the 80% of the calves will be laying down immediately after that. And perhaps those calves still standing after that time when 80 or 90% of the calves lying down is a better way or time to look at screening. So we have inaccurate detection methods, we have personnel limitations, we have limited equipment, maybe animal contact is required for the screeners, and so a number of these things result in the fact that routine screening is, if it's done, maybe not done with the accuracy and the sensitivity that we want. And to show that, I took data from the last 7 farms where we were looking at respiratory disease problems in calves specifically and seeing how the farm would measure up with how the veterinarian detected disease. And that's many of the survey numbers that we looked at this morning were producer-detected disease, and this subset of sample farms should show you. So on each of these farms, this column shows the number of calves that we did score, and that is to look for respiratory disease. In the third column, we see the number actually affected by having at least 2 signs, clinical signs, consistent with respiratory disease. And then in the final column, the ability of the farm, or the number of animals that we detected compared to the number that the farm detected. And you could see clearly the farm, if these are true respiratory diseases, there's a great missed opportunity to intervene. And the consequences of that, I think many of us recognize that endemic dairy calf pneumonia is a problem on many, many, many dairy farms. Heavy antibiotic use, few cures, high recurrence rate. I would say an increased level of prophylaxis. My new colleague, Dr. Olivet, and I were at a farm where prophylactic use of antibiotics or metaphylactic use of antibiotics occurs at 3 different times at a cost per calf of a large amount of money exceeding $25. So we have heavy antibiotic use. We have refractory sequelae. Even if you don't agree with a number of the long-term consequences, the sequelae of untreated respiratory disease is significant. So let's delve into the scoring system. The Wisconsin scoring system that we used, that I developed, and basically it's a simplified system because I wanted it to be farm friendly. It again looks at clinical signs, so it's a clinical science-based detection. Very simple. Rectal temperature, you can see additional points stop at 3. In the categories listed here, we have 0 for normal calves. 1 point means that it could be normal. 2 mildly to moderately abnormal, and severely abnormal. And so I've tried to put these clinical signs into interpretations that could be used by trained individuals on the farm. So rectal temperature and cough scores, these would require a person to move into a pen and have hands on the individual animals. On the other hand, nasal discharge score, an eye discharge score, or an ear discharge score could be done from outside the pen. So in reality, when we score rows and rows of calves, we do the outside the pen detection, and then we go inside the pen detection for the final parameters. And you'll see it's just a graded scale. In this 4th parameter, the eye or the ear score, we take the highest of the 2 scores. And that gives the criteria for 5 points treatable calves, provided at least 2 abnormal categories are present. And this is the paper or online version in the notes. It's accessible for online in the production medicine website at the University of Wisconsin. You'll see that for almost every one of the clinical parameters, save for rectal temperature and cough, there's a picture that goes along with a verbal description. You can have either, and the scores are in the 0 and 1. Calves would be considered relatively normal. When you look at this ear score, I have the picture from this calf, and actually the ear score I would say as a 1 is not normal, but you'll see a calf flicking the ear or a calf trying to use the foot to scratch the ear, and I think that's very mildly abnormal. And then we have a dropped ear or head tilt, bilateral dropped ears and severity. So it's a simple selection of 5 clinical parameters, 4 of which are scored, and calves can have a total score which would indicate that they have respiratory disease interpreted as at least 2 signs of respiratory disease are present. And that means that if I'm away from the time when the fever was there, but the calf has a cough and a nasal discharge, she's going to be flagged as being requiring treatment. We're developing an app version, and the app version, again, will run through all the parameters with a scorer's name, farm name. Comments can be added. Calves can be scored here. You can touch the screen and bring the calf back up after you've done the outside the pen scoring. You can go back in then and finish up with the temperature and the cough score. And it will provide a report back that can be implemented. It can have interpretations and the like. So it's in the final stages of development. As calves are in group pens now, I would suggest that even in group feeding pens of preweaned calves, we still emphasize the need for individual animal contact and exams. But post-weaning or other groups, we can adapt this scoring system for the groups. And now we have the number of calves. And now we just list the number in the pen that have a score 2 or 3 for nasal discharge, abnormal ocular, ear, and then we get into the pen, move the calves around, and then count the calves that are spontaneously coughing. So the group pen adaptation allows a clinical signs detection system that does not require hands-on individual animals. I would still suggest in automatic calf feeding systems with pre-weaned calves that individual animal contact and the temperature and induction of a cough is valuable for this detection. So in the group pens, just summary, you're looking for calves that are scored 2 and 3. Most of the exam happens outside the pen. And then we will consider a pen is involved if more than 25% of the calves in the pen have 2 abnormal signs. So what can you use from the output of a standardized clinical signs scoring system? Well, we can use it as a method of detection for the calves that have respiratory disease and that the veterinarians decide need treatment. We can select calves, use it to select calves for diagnostic testing. Now with a colleague, I may pick all those 5s and higher, and my colleague can go through and do the ultrasound exams. They can do imaging exams. We can do airway sampling or blood testing on a subset of the positive calves. We can find in a dairy problem barns, problem hutch locations. We find a lot of aerosol contamination in hutches that haven't been moved, that hutches that the vents aren't open, hutches that are damp. So hutches aren't without their problems, and we can find where on the farm the problem location of hutches are. We can determine treatment efficacy, recurrence rate, apparent age of onset, which can all be useful parameters when you're working with pre-weaned dairy calves. We can use the output of a scoring system to characterize the calves. In the group of pre-weaned calves, we can have calves with no disease. We can have calves just flagged as having a fever if they get a score 3 or higher. Calves with a cough. Calves with otitis. Oftentimes, otitis may be a sign by itself, and maybe that encourages us to look at Mycoplasma bovis in the milk or prompt us to do some other things. Otherwise, it will give us the calves that have what I would presume is relative confidence in a diagnosis of undifferentiated respiratory disease. But then if we can add another clinical tool to it, like ultrasound, diagnostic ultrasound, then we can subclassify these calves as pneumonia. We can maybe categorize them as upper respiratory or viral pneumonia. And I'll show you that in this slide in a recent herd that I did with Dr. Olivet. And we did the clinical scoring, and then you'll look at the nose, eye, ear, cough scores, temperature score, the total respiratory score, which in this case did not give the positive but summed the eye and the ear, and then the diagnosis after we did the ultrasound scores. So Dr. Olivet's ultrasound scoring system goes from 0 to 5, which is no pulmonary disease, lobular disease, and all the way up to lobar pneumonia. And so at 5, you have lobar pneumonia. So you can see that now with a calf that has all 1s, only a 2 for ocular discharge, she would be classified as, in the total respiratory system, she has a 6, summing these two, but she has only one single parameter that's abnormal, and so she's classified as no disease. Alternatively, calf number 408, she has all 1s, but she has a 2 on her ear score, so she has an eardrop. And so the output on her, when it comes to our system, she'll be called otitis, and she'll be watched closely. In 412, we have a calf that's moderately abnormal nasal discharge. She has a dropped ear. She has when you induce a cough, she coughs many times, and she has 103 or higher Fahrenheit temperature. Okay? So this would classify her as respiratory disease. She also has an abnormal ear score, so she becomes an otitis. And now with the ultrasound, though, she has very, very mild changes, so she's classified as upper respiratory disease. And finally, we can skip down, but here's a calf that has, by the clinical scoring system, 411, has all 1s, but a temperature that's considered abnormal, but her ultrasound examination she has lobular pneumonia, so she's called viral pneumonia, and that's based on Terry's PhD work, where she induced and looked at pathologic lesions, active lesions, old lesions. So we can subcategorize these with additional diagnostic testing. The calculations that can be made from output of a clinical scoring system, we can get single respiratory disease prevalence implemented on a one-time basis to get prevalence. This may not be a sensitive tool. It may lack a little bit in specificity. We can calculate an incident rate. Very useful to me when I'm troubleshooting farm problems is we can tell how well the farm is doing for detecting the rate. And then additionally, we can look at the impact of methods, changes in management, treatments, housing, and see what the effect is on the herd. I'd say the clinical science respiratory scoring system is only one part of dairy calf health management, which would include daily observations. So there are calves on a daily basis that need to be looked at. And those calves may be calves that have appetite aberrations. They may be rechecks from the previous day. They may be calves that completely refused milk or depressed, or they were calves that had a difficult delivery, or whatever we label as high-risk calves. But they're flagged requiring a daily observation. So that daily observation is done when feeders are picking up milk or looking at the computer feeder. The twice-weekly screening for respiratory disease is as I've described. And then for both calves that on a daily basis deserve an exam, or calves on the twice-weekly have a defined exam process, one part of which is respiratory disease screening. And for each dairy, you can make it work for the dairy, what the expectations are. This is a herd where they work very well by signs and by pictures and by on-calf markers. So again, this just shows things begin with daily calf observations. And it's well spelled out, and the workers are trained what they look for on the daily observations. So the expectations are clearly spelled out in the training. And they're performed by the employees doing routine chores. So the people on this dairy that are looking for abnormal signs are not the highest trained people. It's performed when they're doing other chores. But a calf then gets a mark that it requires an examination, a full examination. And then it's coupled with the people doing the screening twice a week, people who are more fully trained and either do a complete health exam or a respiratory exam, and ultimately treatments are recorded on the calf and on the computer, and the expectations are well spelled out. What I'm asking in a clinical signs respiratory screening tool is for extra labor. And on many dairy farms, that is the limitation in calves. And from an intuitive cost of economic analysis from Wisconsin, they estimate that for routine daily chores on the dairy farm, in the preweaned calves, it would require one full-time equivalent per 100 calves. And that's a little bit of an average. The calf raisers are more efficient in it. That can go up to 250 to 300 calves on efficient calf raisers. But when you look from small dairies, tie stall dairies, all the way up to the large size, on average, one full-time equivalent for each 100 calves for routine daily chores. And when we look at health management, that's screening, regular screening, daily exams on those calves that require a daily exam, we'd estimate that that would require another half-time employee per 100 calves. The examiners should be trained and monitored and skilled and very committed. The treatment crew needs to be trained and monitored and very compassionate. There have been a number of dairy farms where the only thing we find is high calves that have a temperature score of 103 or higher, a 3, and it's vaccine reactions in the neck, or it's sub-Q fluid abscesses from calves given sub-Q fluid. So this gets you down, and it finds the weak points in managements, and it gives you that opportunity to reward good work and avoid the conflicts. And if the screeners find more calves that need an exam and the examiners don't want to do the exams, you've got to work through all those conflicts between the individuals. And if the owner or the calf manager is, after them to reduce treatment costs, conflicts can build up. So implementing a scoring system requires a plan. It should be incorporated into a full calf health management plan. I'd say I designed it. We designed it to be twice weekly from birth. Many dairies don't use it until we see the prevalence of respiratory disease go up at 2 to 3 weeks. Many dairies implement it once just prior to weaning, or they implement it just before calves move, make a housing change, or they'll do it to make culling decisions. But with a good scoring system done here, we know that when a calf's getting ready to wean and has been through 3 different treatment protocols and it needs its 4th, there's an ample opportunity to say she doesn't move out of that individual pen. And then you can work with the dairy. Ultimately, the treatment records go into a calf health computerized record, so that could be referenced back when the calf is 2-year-olds and they get respiratory disease for the first time. You can look back and see what happens. But some calves wear the marks on their ear tags. Some calves wear the marks of a nylon tie on the ear tags. Some calves wear it as a placard on the individual pen. That doesn't follow the calves like this kind of system does. But treatment costs can be calculated. I'd like to see benchmarks. What is it we expect on a per calf per day treatment with regard to these calves? We can look at it to follow days to weaning, average daily gain, feed efficiency. And then when prevalence of respiratory disease or health problems go up, it triggers us to do more advanced health management, either treatments or testing. Initially, when we put an effective screening tool in place on a farm, what we find is that the respiratory disease prevalence or incidence is going to go up. And that will discourage some, so it's well worth telling them that initially more calves are going to be treated and the treatment costs are going to go up. So any measures of morbidity go up with good screening. The veterinarian oftentimes is called more often because they perceive now we're in the midst of a respiratory disease problem. But almost initially, mortality rate due to calf pneumonia goes down. Ultimately, over time then, we expect that the treatment rate and the cost goes down because we're catching calves earlier. There'll be fewer days of treatment because we're catching them earlier. The recurrence rates and the relapses will be reduced. The case fatality rate should go down. We should be able to find some of the weak points in the management system when this is regularly done. Replacement heifers ultimately are more productive and profitable, and the workers are happier. The turnover is less. A nice study from Denmark showed that the importance of the calf workers understanding and feeling in control of what they do relative to their performance and their turnover. So it has added value. In summary then, I would say with a clinical signs respiratory disease screening tool in calves, it again needs use. It's as designed and demonstrated today. It's meant to be regularly implemented for early detection and effective treatment in calves. It needs validation. It needs assistance for some of the diagnostic tools, the whisper, the ultrasound, to look at that. I've done it with the BAL scoring and things like that. But early detection promotes health, chronic consequences are reduced, and the endemic respiratory disease problems in dairy calves go away. So actually, you're not allowed to get questions now. I think we have another talk, but thank you very much for your attention during nap time.